liver is one of the most important organs in your body, and in fact there's very little that goes on in your body that the liver isn't involved in. It's kind of like the powerhouse of everything that happens, and the liver has some really, really important roles. For example, when you eat a meal and your gut digests the meal and the nutrients are absorbed from your gut, your liver processes those nutrients and packages them off to do all the things that are needed in the body. But the liver also is important for excreting things and getting rid of toxins and medications and other byproducts that the body doesn't want as well. And it's also involved in the synthesis of things like vitamins and other essential things for the body to function. It's also involved in the immune system as well, and many people, I think, don't appreciate that, and also in the metabolism of glucose. So when your liver's sick, you're more likely, for example, to develop things like diabetes. EASL is a global platform for hepatology across the world, and we have a membership of more than 7,000 people across 120 countries. And really the aims of EASL are four. We have four pillars. One is education, one is advocacy, one is science, and one is leadership. And in terms of science, what we want to do is really encourage and develop and present the latest scientific research and findings, actually to translate it into better patient care. And that's really the heart of everything that we do. So that actually what we do is we take the science and the research and the knowledge and help to evolve that into delivering the best possible care across the globe. ACLF, which actually stands for Acute-on-Chronic Liver Failure, is really a type of liver failure that develops on top of already having established liver disease. So anybody who will develop ACLF, they will already have underlying liver disease, and that will usually be liver cirrhosis. And what liver cirrhosis is really an end-stage type of liver disease where the liver has become scarred and shrunken and struggles to do the things the liver needs to do. But actually the liver's very good at coping with, even when it's sick, with doing things. But what happens with ACLF is that something happens to the body that actually is sort of like the last straw, and actually the liver that's been coping all the way along suddenly just sort of falls apart. The precipitating factors are usually some sort of inflammatory event, or most commonly an infection. And what that does is that infection and the inflammation within the liver just causes the liver to really stop functioning as it should. The downstream effect of that is that the liver produces lots of inflammatory molecules that go into the bloodstream. The blood becomes inflamed, and then what happens is subsequently all of the other organs in your body start to misbehave and to fail. And what I'm talking about here is the brain. So you can develop a condition called hepatic encephalopathy. It can affect the heart, so you can actually fail to maintain your circulation and have low blood pressure. It can affect your kidneys, so you develop kidney dysfunction or kidney failure. You might even need dialysis. It affects the way the gut functions, and even your respiratory function. You can get inflammation in the lungs, and the lungs can also develop inflammation and a requirement for your body to need to go onto a ventilator. So what happens when these patients are with ACLF develop organ failures is that inevitably they need to go to a high dependency or an intensive care unit where they need to be managed with organ support. It's difficult to diagnose because, unfortunately, about 70% of all patients who present to the hospital for the first time with liver disease, so these are individuals who did not know that they had liver disease. And so when they present to the hospital, they are really, really sick, and it's sort of come out of nowhere, really. So what makes that difficult to diagnose or to get a handle on is the fact that, you know, people are unaware, the patients, but also the healthcare practitioners that are assessing them, that this individual has liver disease. So really it's about piecing everything together and working out what's going wrong. The problem is also that because these people have effectively been quite well and their bodies have been compensating all this time, suddenly they get sick very quickly, and it's like being hit by a car or a train. They suddenly go from being really quite normal to being really incredibly sick. But in a matter of hours or within a couple of days, they can go from being at work to literally being in the intensive care unit. And it's a devastating disease in the rapidity of how quickly people deteriorate and become sick. It's a huge area of unmet need, and I think our understanding of ACLF, or acute-on-chronic liver failure, has really only come about in the last 20 years. So I was here at the Liver Congress 20 years ago in 2004, when really we had a kind of first meeting or symposium where we actually got experts together who manage patients with advanced liver disease into a room to try to talk about this condition. And really what we started to think about is ways in which we can stop this really sort of rapid decline in our patients with liver disease, how we can intervene to actually prevent worsening organ failures. And unfortunately, this is a condition that has a significant mortality. And many patients who are admitted to the hospital with ACLF will unfortunately not leave the hospital. Depending on the severity of the ACLF, and we can grade that in different ways from mild to moderate to severe, but in those patients with severe ACLF, the mortality is significant, in excess of 70% and often approaching 90 or even 100% in those that are really sick. I think we need to approach this in two very separate ways. I think the most important way is prevention is always better than kind of cure. And actually, there's a huge piece of work that we need to do to better identify people with liver disease in our communities. So, you know, as I say, 70% of people won't previously be diagnosed. So actually, we need to work very hard to try to identify people with undiagnosed liver disease that actually we can manage at an early stage so that they don't actually ever develop ACLF. But of course, as I mentioned to you before, a large proportion of those patients won't know they've got liver disease, and they will unfortunately present very sick very quickly. And therefore what we need to do is to develop therapies that can actually halt or improve the organ failures, and to actually try to turn things around for these patients and actually get them out of intensive care. And some of the therapies that I think we've been looking at in kind of research settings are therapies that might reduce inflammation in the liver and in the bloodstream particularly, or the sequelae of inflammation and infection in the bloodstream that actually is one of the main contributing factors for why patients develop organ failures and why they end up in the intensive care. The more organ systems that are affected in ACLF, the worse the prognosis. So if you come in with ACLF and you just have an impairment in one or two of the organs, you do much better than if you have an impairment of all of them. And we know that patients, for example, with hepatic encephalopathy, actually if they're managed very well in a high dependency or intensive care environment, they do very well, because actually good management can help these patients stabilise and actually wake up from the encephalopathy. It's sometimes harder when patients have got significant effects on their heart and their blood pressure. And patients who require medications to increase and keep their blood pressure high enough to perfuse their organs, they're often much sicker. And when patients actually are affected by kidney failure as well, that can be really, really tricky. Patients may need a dialysis or hemofiltration. And when you have a combination of all of those things, it really gets difficult to manage. And those are the patients, unfortunately, that have the worst outcomes, particularly also if they develop bleeding. And one of the things that can develop in patients with advanced liver disease and in ACLF is that they have varices, which are dilated varicose veins in the gullet or the stomach. And when patients are very sick, when they have ACLF, they're more likely to burst these varices and to bleed, and that can be a huge issue to deal with. I think the thing that governs the management of ACLF is because generally these patients present very rapidly, usually out of nowhere, they're going to present to their local hospital, whatever that might be, whether that be a small district general hospital to a tertiary referral, or even if they're lucky enough, potentially a transplant centre. And they'll present usually through the emergency room, the accident and emergency, where they're seen and managed acutely. And many of these patients will be so sick that they'll automatically be seen by gastroenterologists or hopefully hepatologists, but often intensive care colleagues as well at the same time, particularly if they're very sick. And then these people usually will go to the ward, but if they're too sick, they will go immediately to a high dependency or intensive care area. Now, what ideally happens is that they go to a centre that's got the expertise to manage it, but not everybody's lucky enough to do that. It very much depends on where you live and how remote you are, and if you're lucky enough to live next to a transplant centre. But what will inevitably happen, and this is a good thing, is that hopefully when patients who are very sick that go to smaller hospitals, they will call colleagues in the more experienced tertiary referral centres and transplant centres, looking to get the patient referred, or at least to get expert advice as to how they should be managed and whether potentially they could even be a candidate for liver transplantation. I think it's important to say that unfortunately many patients who present with ACLF are often very sick and that they may not be candidates for transplantation for a variety of reasons. It could be because they're too sick or they're too old. It could be because they've got an etiology of their liver disease that may preclude transplantation, and that can particularly be an issue with patients who have active excess alcohol use, because we want to transplant people who have the best likelihood of having good outcomes, and therefore some of the factors are taken into account when these decisions are made. EASL, as I say, is a global platform where we work really with a huge community of healthcare practitioners across the globe. And it's important to say, I think, that we collaborate with our kind of international sister societies. So I'm talking about our counterparts, ASLD, APASL in Asia, LA in South America, Calder in Africa, and we all work together in that way. But also we liaise with individual societies in Europe and further afield that may have expertise in these areas, and we're really actively encouraging collaborations with societies. For example, we, EASL, are working very closely with ISHN, which is a society specifically has an interest in management of hepatic encephalopathy, just to give you an example. And we're also working with other societies also that have specialist interest in obesity and diabetes as well. So yes, we do try to collaborate closely and work together, particularly when there's a lot of overlap in what we do. The intensive care societies and how they develop guidelines around managing patients that are very sick with organ failures, it's also very important to make sure that we are all aligned as well. I'm pleased to say that EASL released a clinical practice guideline, or CPG as we nickname them, on ACLF, and we have a very, very comprehensive clinical practice guideline on really all aspects of the management of ACLF, from admission through to the pathways that these patients take, the therapies that they require, and how you manage the organ failures, nutrition and so on. Our CPGs are actually available on an EASL CPG app, so actually anybody can refer to this guideline on their smartphones. It's readily available in any clinical setting, and we're very proud that we've done that. Absolutely. I think because we've kind of got a tsunami of presentation of liver disease, it's on the rise across the globe. And when you have a rise in liver disease, you're going to have a rise in the incidence of acute-on-chronic liver failure. It goes without saying. And yes, because of that, and I think because people get very, very frustrated that they have very few options for these people, it's really generated a lot of interest and a lot of research in this area. But trials in ACLF are not easy to undertake, actually, because you've got a very, very sick population of individuals who often are too sick to be able to read a patient consent form or to understand the risks and benefits of a trial. So you often rely on talking to their caregivers or their next of kin or other healthcare professionals that look after them to make the decisions about whether actually you can enrol these people in trials. But the interest is really growing, and it's a huge area of unmet need. EASL prioritises all types of liver disease, and I think it's important to say that any type of liver disease can progress to ACLF. It's not one particular type of liver disease, it's any type of chronic liver disease can progress to ACLF. So therefore, for EASL, it's a priority that we not only address the underlying liver diseases themselves, but the progression of those diseases to ACLF. We are very passionate and engaged in managing patients who have advanced liver disease, who have a condition called portal hypertension, which is really a manifestation of advanced liver disease all the way through to acute-on-chronic liver failure. So it's very much at the top of our agenda. I think one of the problems with ACLF, as I mentioned to you before, patients are very sick, and it's very difficult to roll out trials in very sick populations of patients who often have poor outcomes regardless of what you do. We want to develop therapies that actually patients can easily access. So, my message to the industry that are developing therapies in this area is that actually we want to be able to roll out therapies that are accessible to many patients, and that actually when we do these trials, the clinical trials, that we make them very, very much real world studies that actually we can enroll large numbers of people in. We want therapies that really can be rolled out and be applicable to many individuals, and that's going to make such a difference.